ఇప్పుడు ఐ డోంట్ నో అంటే వాట్ షీ టోల్డ్ ద రీజన్ ఈస్ జస్ట్ అబౌట్ డోంట్ వాంట్ టు వెన్ సంబడి మోర్ ప్రొఫిషియంట్ దెన్ మీ ఈజ్ అవైలబుల్ ఐ డోంట్ వాంట్ టు వెంచర్ ఇన్ టు ఇట్ అని చెప్పేవారు ఆవిడ ఉన్నప్పుడు.
ఓకే.
సో దట్స్ ద రీజన్. ఐ మీన్ లైక్ ఏబిసిలో ట్రెకియోస్టమీలు ఎక్కువ చేస్తాం సార్, బట్ ఆల్ ఆఫ్ దెమ్ ఆర్ 100% సర్జికల్ ట్రెకియోస్టమీస్.
We are also only surgical.
Right now also
Mohan Rao is doing all percutaneous.
Percutaneous. అపోలోలో కూడా ఐ థింక్ అచ్యుత్ సార్ ఇస్ డూయింగ్ సార్, అంటే నవీన్ సార్ చెప్తుంటారు.
అవును.
Right now also we have 2 cases sir on tracheostomy, both trauma recovered well. One case actually came in gasping. I thought he's gone. Elderly fellow gasping lo వచ్చాయి, but it's now recovered well. Both of them are on TPs now.
Okay.
సో స్క్రీన్ విజిబుల్ కదా సార్? ఫుల్ స్క్రీన్ స్క్రీన్ విజిబిలిటీ ఉంది కదా సార్?
ఉంది.
స్లైడ్స్ ఉంది.
Sir, any personal experience tracheostomy complications, sir?
ఎవరిని?
ఇద్దరిని సార్ మీకు గుర్తుందా ఒక కేసు?
నన్ను సార్ మిమ్మల్ని
ఏదంటారా ముసలాయన ఒక విఐపి.
విఐపి ట్రెకియాస్టమీ, ఎలెక్టివ్ ట్రెకియాస్టమీ అని చెప్పి సిటిఓటీలో టేబుల్ లో పెట్టారు. డిఫికల్ట్ ఇంట్యుబేషన్, డైరెక్ట్ ట్రెకియాస్టమీ అని.
అవును.
ఇంకొచ్చిందా? చూపు పాస్ చేయలేదు మళ్ళీ ట్రెకియాస్టమీకి.
అవును అవును. గుర్తుంది. ఏం చేసావు అప్పుడు?
సక్సెస్ అయ్యాం థర్డ్ అటెంప్ట్ లో. అదొక ఎక్స్పీరియన్స్. నెక్స్ట్ ఇది కిరణ్ ఏమో బెడ్ సైడ్ పెర్క్యుటేనియస్ ట్రెకియోస్టమీ, సివియర్ బ్లీడింగ్, అదొకటి. థర్డ్ది సర్జన్ అనేబుల్ టు పాస్ ద ట్రెకియోస్టమీ ట్యూబ్, ఫాస్ట్ ట్రాక్. అది కూడా డిఫికల్ట్ ఇంట్యుబేషన్ పేషెంట్, మళ్ళీ రీఇంట్యుబేట్. అది ఒకటి.
అదే మోర్ ఇంపార్టెంట్, మోర్ కాంప్లికేషన్ వచ్చిందంటే ఇట్ ఈస్ డెడ్లీ ప్రొసీజర్.
నెక్స్ట్ ఇంకొకటి అంటే నెక్ సర్జరీ ఉంది. సో ఐ టోల్డ్ టు సర్జన్ ఫస్ట్ ట్రెకియోస్టమీ ఫాలోడ్ బై ప్రొసీజర్ అన్నా. ఆయన వినకుండా ప్రొసీజర్ ట్రెకియోస్టమీ అన్నారు. సో ఫాస్ట్ ట్రాక్, అనేబుల్ టు వెంటిలేట్ ఆల్సో. ఆల్రెడీ అంటే ఇంట్యుబేషన్ కూడా ఇంకా స్పేస్ ఏమి లేదు, అంత బ్లడ్డీగా ఉంది. ఆయనేమో మెటల్ 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 అని అరిచారు. ఇంకా ఆయన గురించి అని మెటల్ తెప్పించి నేను డైరెక్ట్ ట్రెకియోస్టమీ దాంట్లోనే వేసేసా. అంటే ఐ మీన్ 6 ఈటీ ట్యూబ్ 6 చేసి
uh,
రైల్ రోడ్ లాగా సక్షన్ కథెటర్ పెట్టి ఫాలోడ్ బై ట్రెకాస్టమీ పెడతాం కదా, కొంచెం అది చేసాం.
స్టార్ట్ చేద్దాం.
ఓకే సార్. Okay, good morning, everyone. So, sir.
I will introduce.
Okay, sir.
నువ్వు తెలుసా మీకు అందరికి?
తెలిసే ఉంటుంది సార్ మోస్ట్లీ.
ఫార్మాలిటీ అంటారు కదా, మేము కూడా కొంచెం చింతలేయాలి కదా. Good morning, all of you. Welcome, Dr. Srikanth. First time enter the dragon into the critical care. Now the critical care is enlightened by entry of Dr. Srikanth. And I wish you all the best for this presentation and coming presentations also.
Thank you, sir.
Srikanth is a senior consultant and head of the Department of Anesthesia and Critical Care ABC Hospital, Visakhapatnam. And he worked under Dr. Kavita Madam. Under Kavita, all of you know that she is a very good, very qualified intensivist, and he was trained under her. Now I request Dr. Srikanth to start the presentation.
Thank you so much, sir. Thank you for the opportunity, first of all. When I thought about first critical care class, thought of like 3 topics which are moving in my mind. Or one is tracheostomy, the second one is steroids in ICU, and the third one is use of hallucinated agents in ICU. What are we waiting for? So these two are based on articles, and steroids is a textbook topic. So out of this, I choose a relatively safe bet guidelines part for the first class, so that moving on, I can actually venture into more serious topics in ICU. So with that, we'll start today. This is basically, this class is about ISCCM expert panel practice recommendations on tracheostomy. So this they have based on a study called DISSECT study, which they have conducted in 2019 ending, and around 78 ICUs were enrolled in that study, and out of that 67 participated in that. So they compared PDT, percutaneous dilatation tracheostomy versus surgical tracheostomy in adult intensive care units. I mean, like these tracheostomies were, and guidelines were developed for more than 18 years of age patients. So, as I told, this document presents the first Indian recommendations of tracheostomy in adult critical ill patients based on the practice of the country. So these guidelines are expected to improve the safety and extend the indications of tracheostomy in critically ill patients. So the compilation of recommendation was done at the consensus meeting of a group of expert intensivists from across the country, and which included our Samvedam Srinivas sir also, and also based on the information obtained from the multicentric observational study, DISSECT study, dilatational percutaneous versus surgical tracheostomy in intensive care unit, practice pattern observational multicenter study. So the recommendations of this document are applicable only to individuals who are above the 18 years of age. So coming to initial DISSECT study, which is actually published in July 2020, the study was conducted between September of 2019 to December 31st, September 1st to December 31st, for a period of 4 months. So around 923 tracheostomies were conducted during that period, and that specified ICUs of 67. Most of them are, I mean, like 88% of them were private hospitals compared to public hospitals were around 19%. So they have collected, there is a national principal investigator who will be analyzing the data, and each hospital has another principal investigator of that particular ICU. So ethical committee approval actually was not needed for this study according to them, because they are not altering any practices or introducing a new intervention. They are just following the routine ICU protocols what they have, and they are just reporting the study back. So they have patient demographics were submitted in the form of online case record form. So online case record form has like variables they termed it as PICO, patient intervention and outcome, competence and outcome. So they have, in this study they have like we'll come to know in few slides what are the scope of study and indications and all. They are mainly according to this study, most of them, or at least like 75% of the people, they preferred percutaneous dilatation tracheostomy over surgical tracheostomy. But again, it's a learning curve, and it requires definitely expertise to carry out PDT, because the complications can be devastating sometimes. So this is the guidelines journal which was published again in the ISCCM in 2020. You can see our Samvedam sir name over there. So coming to this tracheostomy, these definitions and all, we know surgical tracheostomy, there is a surgical cutting of pretracheal fascia and creating an opening between the rings, and percutaneous, whereas we have carry out a blunt dissection of the pretracheal area and insert the tracheostomy tube. Again, there are multiple techniques of percutaneous dilatation tracheostomy. I personally don't have experience or this PDT. Anyone with an experience of PDT we can discuss this later. So in this among the various techniques, single dilator, multiple dilator, and Griggs forceps technique, according to the dissect study and also based on other international journals, the single dilator technique, being a relatively easier one to learn, is the most preferred technique. I mean, like 67% of the clinicians, they prefer single dilator technique, compared to followed by Griggs forceps technique and followed by multiple dilator technique. So this is what we are telling about initially: patient PICO, patient intervention, comparison and outcome. This is how they graded the patient related variables, and the quality of evidence. They have taken this grading system into account, where level 1 is evidence from more than one good quality and well randomized RCT, and the decreasing in quality of the evidence from 1 to 2 to 3 and all. Useful practice point is where there is no evidence, or I mean, like there is no sufficient evidence, but however, a consensus is reached by the working group based on the clinical experience and expertise. Also, the strength of recommendation is grade A is a strong recommendation and grade B is weak recommendation. Coming slides will be knowing about recommendations. So this grading system we have to keep in mind. So where 1 carries the highest value and A carries the highest value. I mean, like there are the strong quality of evidence. So the scope of guidelines, the indications of trachea, what they have studied through this study, I mean, like again, these dissect studies have few limitations, like the data is not validated. I mean, like if I'm sitting in my ICU and sending the data to this study, there is no validation, like whatever the input that has been given was treated as correct, because most of the clinicians, it's not made mandatory by ISCCM. They have been collected voluntarily. So and also they have not taken into variables like long-term mortality or some like ventilator-free days. There were no, data was inaccurate in terms of collection. So those things have been mentioned in the limitations of the study. So which is why they have also, when the ISCCM guidelines were made, many international papers and randomized controlled trials were taken into account. All these mixed along with the dissect study, they had developed the guidelines for our Indian scenario. So the indications of tracheostomy in ICU, the choice between surgical and percutaneous tracheostomy, the guidance used during tracheostomy, the immediate complications of tracheostomy, the weaning time frame after tracheostomy, and the average cost of this procedure in India. So tracheostomy in special situations like morbidly obese and coagulopathic patients, and these guidelines are used only for the adult patients with more than 18 years of age. So coming to indications and contraindications of tracheostomy. So indications are, as we all know, prolonged ventilation, weaning from ventilatory support when it's especially difficult with the ET2 in place, tracheobronchial toileting and secretion management, upper airway obstruction like in some malignancies and all, where we will not be able to pass the ET tube, or very undersized ET tube is passed, which will not allow for adequate ventilation, permanent airway control like in malignancies or trauma or neurological conditions. So coming to contraindications, where some of the relative contraindications used to be in absolute earlier, like in coagulopathy and morbidly obesity and all unstable C-spine, all these are used to be like an absolute contraindication for tracheostomy earlier, but with increasing expertise of the clinicians in the ICU to perform bedside tracheostomy is also the advances of gadgets like ultrasound and fiber optic bronchoscopy has made these comparatively relative indications, where according to the DISSECT study itself, many centers they have carried out percutaneous tracheostomies where INR is more than 1.5 and also platelet count with less than 50,000. So, so the absolute indications, thirst and obviously informed consent not available, and infection at the site of tracheostomy. Only these two are absolute contraindications. Relative contraindications are coagulopathy, altered neck anatomy like thyroid mass or swelling, unstable C-spine, morbid obesity, and patients on ventilator support with high PEEP. These also we are now carrying these with high PEEP support. We are doing bedside tracheostomy for this, even though they carry a slight risk during the transition period, where we will just cut open the throat tracheal fascia, and then before inserting the tracheostomy tube, that period is prone for again rapid desaturation in the patients with high PEEP, needing high PEEP. So the recommendation is there are no absolute contraindications to tracheostomy except refusal of consent and infections at the site of planned procedure. So this is a big $1 million question when it comes to tracheostomy, whether to do an early tracheostomy or delayed tracheostomy. Across the country in various ICUs and also in the various randomized control trials, or in, even through the international literature also, there is no clear-cut definition of what an early tracheostomy is. Many people taken it as 1 to 4 days. After 4 days, it's a delayed tracheostomy. Some people have taken 7 days or 10 days in some studies. So when these guidelines were framed, they thought of within 7 days, if the tracheostomy is done, it's treated as early tracheostomy, and after 7 days, if it is done, it is treated as delayed tracheostomy for the guidelines purpose. So does early tracheostomy, when it comes to early tracheostomy, there has to be some advantage when we are doing it in early. So all these questions came in the guidelines, like a set of 3 to 4 questions, where does early tracheostomy actually reduce the incidence of ventilator-associated pneumonia as compared to late tracheostomy? So in this particular review, where they have done, and also like there are several 3 to 4 journals that are cited over there. So I picked up from 1 or 2 for each one. So in critically ill adult patient who required prolonged ventilation, I am reading the conclusion part here. Performing a tracheostomy at an earlier stage than is currently practiced may shorten the duration of artificial ventilation and length of stay in intensive care, but it doesn't alter the ventilator associated pneumonia incidence. So which was result in the results, it has given that risk of pneumonia was also unaltered by the timing of tracheostomy. Even in studies where they have shown some significance of ventilator associated pneumonia incidence, even those studies were not statistically significant. So which is why they have not taken into consideration. So the recommendation is the incidence of, when I talk about this recommendation, this is the recommendation put forward by our ISCCM for the guidelines for the country to practice. So the incidence of VAP does not change with early within 7 days of ventilation or late tracheostomy, which is a very strong recommendation, quality of evidence over here with 1A. And also early tracheostomy should not be used as a strategy to reduce the incidence of VAP. So here comes the next question. Does early tracheostomy reduce the ICU length of stay as compared to late tracheostomy? Which is again the second big advantage if it actually reduces the ICU length of stay. When they carried out the total length of ICU stay, many studies have suggested that Early tracheostomy may be able to reduce the duration of sedation, but it did not significantly alter the mortality, incidence of ventilator-associated pneumonia, duration of mechanical ventilation, and length of ICU stay. Length of ICU stay was mostly unaltered when compared to when we compare with early tracheostomy and delayed tracheostomy. So this is another study where they have found earlier ICU discharge, shorter duration of mechanical ventilation, and decreased overall length of hospital stay. These conducting studies I have kept because the input is from different very large group of articles where they have filtered out everything and made the guidelines, which most studies or where the quality of evidence is very high. So the recommendation is early tracheostomy may result in reduction of ICU length of stay as compared to late tracheostomy. In my personal experience of these 8 to 9 years also, I have seen definitely this early tracheostomy within 7 days when we conduct, we have seen definitely decreased ICU length of stay when compared to delay or not performing tracheostomy, because as we all know, some patients or they will not give consent to tracheostomy, like hole in the neck and all. They will feel something scary, and whatever way we counsel, some people don't agree. So we have seen clearly this results compared to ICU length of stay when we have done early tracheostomy. So comes third question: does early tracheostomy increase the ventilator free days as compared to late tracheostomy? So this is another review article where the results say, early tracheostomy is associated with higher tracheostomy rates and better outcomes, including more ventilator-free days, shorter ICU stays, less sedation, and reduced long-term mortality compared to late tracheostomy. So the recommendation is early tracheostomy may reduce the duration of mechanical ventilation and may result in more ventilator-free days critically ill patients. This slightly weaker quality of evidence, but still it holds good. And also even in the DISSECT study, what our people have done, they have found more ventilation-free days when compared to late tracheostomy. Also in early tracheostomy, they have found comparatively more ventilator-free days in percutaneous dilatation tracheostomy group compared to surgical tracheostomy. But again, that significance is not so status, that p-value is not significant enough, but they have found some additional advantage when related to ventilator free days in PDT group. So again, this comes, does early tracheostomy reduce the mortality in critically ill patients as compared to late tracheostomy? So here again, this long-term immediate mortality they calculated in DISSECT study, but long-term mortality is not taken into account in DISSECT study. So they have extrapolated the international data to our clinical guidelines. So there is no difference in short-term and long-term mortality between early and late tracheostomy. So the patient with stroke and those under, again in general population it is this, and when they compared in patients with comorbids like neuro patients and cardiac patients and all, so they have seen definitely reduced short-term mortality with early tracheostomy in these patients. Even though the quality of evidence is poor, they have found more advantage in patients with comorbids. Even in DISSECT study, they say cardiac patients, when it came to cardiac patients, the percutaneous dilatation technique is more preferred or surgical, because they can carry out as a bedside procedure for that, needing less amount of sedation. So percutaneous dilatation versus surgical tracheostomy, what you will prefer? So does surgical tracheostomy results in lower complications as compared to PDT in critically ill patients? Again, here it has been divided into immediate and late complications, and into serious, intermediate, and minor complications. So sorry, immediate complications like hypotension, desaturation, blood loss. Again, in our DISSECT study, they have given made the rule that they use 5 centimeters into 5 centimeter gauze pieces to mop the area. So if it is completely soaked, they have taken as 5 ml of blood loss. If less than 5 ml, 15 ml or 3 gauze pieces soaked during the procedure of PDT, it is taken as minor blood loss, and more than 15 ml of blood loss is taken as major blood loss. So in various RCTs, there was no difference in intermediate like desaturation, hypotension, posterior tracheal wall lesion, cannula misplacement, switch to surgical technique, or serious complications like death, pneumothorax, pneumomediastinum, complications between ST and PDT. Both techniques, they have found no difference in this serious complications. And minor complications like hemorrhage and difficult tube placement was more in PDT group, which is quite understandable because again in PDT, it comes from various centers. Some centers may have expert clinicians, those who are well versed with percutaneous dilatation technique, and it also come like institutes where they can do training to students and all, and also junior consultants can carry out the PDT where the difficult tube placements and hemorrhage or likely complications. Um, Again, other minor complications like cosmetic sequelae and post-operative infections have been obviously higher with the surgical tracheostomy. And also skin incision size was similar, smaller with percutaneous dilatation technique. So as per the DISSECT study, PDT had marginally higher incidence of intraprocedural minor bleeding and desaturation, but surgical tracheostomy had higher incidence of major complications. This you can see the difference in our DISSECT study, which was conducted in India. They have observed surgical tracheostomy has higher incidence of major complications, but when the other journals, everything is taken into account, internationally there is no difference between PDT and surgical tracheostomy, even when compared to serious life-threatening complications like bleeding, hypotension, and bronchoalveolar lavage. After tracheostomy, if they do it for secretions and blood clots, they have taken that as major complication. And incidence of complications is similar with between. So the final recommendation what they have given after taking into account all of these is incidence of complications is similar between surgical tracheostomy and percutaneous dilatation, except for a higher incidence of stomal infection and a bigger scar with surgical tracheostomy, which is 1B grading. So does surgical tracheostomy results in cost reduction for ICU patients as compared to PDT? So this is definitely more cost effective percutaneous technique compared to surgical. As we can see, we have to pay for the OT charges and also surgeon and also PDT, whereas clinician, if it takes some amount and the kit cost. So definitely PDT is more cost effective compared to surgical tracheostomy. So the technique, does any technique of PDT, I mean like single dilator, they have compared the technique, Griggs technique and multiple dilator and also various other names, even I am not aware of all those techniques and all. So they have given, compared like 6 to 7 compared to studies of different techniques of PDT results in lower complications in critically ill patients. So in DISSECT study, single dilator technique was the most preferred technique, followed by Griggs technique and then multiple dilator, which is a staggering 60.4%. I mean, like 2/3 have followed the single dilator technique versus 28.7 for Griggs and 11% for the multiple dilator. So even though the technique of single dilator is the preferred one, all the techniques of PDT do not differ in the incidence of complication rates. And single dilator technique is maybe used by less experienced operator. Again, this is an UPP, like useful practice point, which is mostly based on the clinician expertise, where they have preferred single dilator technique to the less experienced because it is easy to teach to them. Does the use of fiber optic bronchoscope while performing PDT reduces the complication rate? Yes, definitely. Fiber optic bronchoscope, any technology which will aid to us, but again, there is a learning curve and it's operator dependent. Will be used whenever available to aid PDT, although it does not reduce the rate of complication. This is again a useful practice point and not a quality evidence. And then comes our savior in all the fields nowadays. Does the use of real-time ultrasound of neck while performing PDT reduces the complication rate? So again, when it comes to ultrasound, there are like 3 levels of visualization. We use the vascular probe. So the field is said to be excellent when there are no blood vessels in the needle tract. Generally, the first to second and second to third tracheal rings is where we will puncture, and the isthmus doesn't come in the line. And it is termed as good when there is a single blood vessel in the center and isthmus may come into picture. and it is graded as unfavorable when there are multiple blood vessels and also isthmus is coming into our surgical field. So this is the grading using pre-procedure ultrasound, and we have to take the call based on that. So use of real-time ultrasound could identify correct position of puncture, decrease the number of puncture attempts, and intra-procedural hemorrhage. So whenever available, ultrasound should be used to scan the neck to identify anatomy prior to needle puncture. And PDT should be performed under real-time ultrasound guidance whenever expertise is available. So experience, is there any minimum number of tracheostomies required to safely and independently perform the procedure? In the dissect study, most of the tracheostomies were performed by experienced operators having more than 25 tracheostomies. So around 87.4% of practitioners who have submitted the data to dissect study, they are very well experienced in conducting the tracheostomies, percutaneous ones, and each one has done more than, on average, they have each clinician has done more than 25 tracheostomies. So the minimum number of supervised PDT may be at least 10 to do the procedure independently. This is what the guidelines say based on all the data, and again it's a useful practice point. So is there an appropriate specialist to perform tracheostomy? So as per the dissect study, most of the tracheostomies were performed by intensivists, which is half of the total amount, 53.8%, followed by surgeons and followed by trainees who are mainly, surgeons are doing the surgical tracheostomy, followed by trainees who are mainly anesthesiologists posted in ICU, and then interventional pulmonologist with a very minute amount, 0.8%. So the guidelines say any intensivist proficient in airway management can actually perform percutaneous dilatation technique, and which is again a UPP. So coming to special conditions, which are actually previously used to be absolute contraindication, with the advent of technology and also expertise and all, these are more to relative, and PDT can be safely performed in coagulopathic patients after appropriate correction of dearranged coagulation. So use of fiber optic bronchoscope or real-time ultrasound can reduce the complication in coagulopathic patients. Newer anticoagulants and antiplatelet agents may be stopped if feasible before performing tracheostomy. So again, when they have done in the dissect study, they have seen the less blood product transfusion requirements, and less even they have carried out with INR more than 0.5 and platelets less than 50,000 in with percutaneous dilatation technique in bedside patients. So according to dissect study, in these special conditions, PDT was more preferred than surgical tracheostomy, and again can be safely performed in morbidly obese patients. This is one of the indication where they found in a retrospective questionnaire when they have done again on the guidelines by Kumar et al. So most of the people when they opted for surgical tracheostomy, they were again asked why you opted for surgical tracheostomy instead of doing percutaneous dilatation technique. And obesity is definitely one of the major indication they have told in opting for surgical tracheostomy. And the main reason which was found in the retrospective audit was 34.2% of the cases where they opted for surgical tracheostomy in place of PDT, they have done because of the admitting consultant opinion, and followed by short neck and obesity are the major concerns where they opted for surgical tracheostomy. So here again, use of real-time ultrasound can increase the safety of performing, and also use of fiber optic bronchoscope is more in obese patients, but there is no difference in complications. So to conclude the guidelines, the scope of this document is for intensivist and medical practitioner dealing with critically ill patients. PDT is the most preferred technique of performing tracheostomy in critically ill patients. And coming to the technique, single dilator technique is the one with maximum experience. So the timing of tracheostomy does not affect the incidence of ventilator-associated pneumonia or mortality, but increases the ventilator-free days and leads to cost saving. Both bronchoscopy and ultrasound guidance can be used to perform PDT, but the preference now is being tilted towards ultrasound compared to fiber optic due to non-inferiority to fiber optic. I mean, like they are equally comparable in providing the assistance, and ultrasound being relatively easily available in most of the hospitals with cost effectiveness. So PDT has a learning curve, and at least 10 assisted percutaneous dilational tracheostomy should be performed under supervision before performing the procedure independently. So these recommendations have been taken into account certain points mentioned in other international guidelines available on the tracheostomy. So thank you so much.
Thank you, Sik, for a nice presentation. The recommendations from the ISCCM expert panel and various tracheostomy procedures and the difference between the PDT and the surgical techniques. My experience in PDT is not much, maybe few cases done, but I have not experienced that. Dr. Mohan Rao is having more experience. I think he can share his experience of PDT. And it is, I think Mohan Rao sir is not there. Hey,
Srinivas sir. Sir,
Ah,
good morning.
yeah,
I think will give
I have a good experience. Most of the at least 4 to 5 PDTs we do per month. We have encountered few problems. First thing is minimal bleeding. So we need to see that with the help of an ultrasound, if there any vessels are there coming in the middle. And every step you should be very cautious, and you should have a good control of hand. And one more thing is we have sometimes while doing the tracheostomy, percutaneous tracheostomy, we may sometimes go into the esophagus also. The tube may go into the esophagus also. So we need to identify, because most of the times we don't do with the help of a bronchoscopy. We go through the ultrasound, or we blindly we go. So sometimes we may encounter entering into the esophagus. Maybe I think 2 times we have encountered into it. And once, very interestingly, we have the tube is in place, but we are not able to ventilate it. So recently, almost 3 months back, we are not able to ventilate. We could not understand why this is happening. So finally, we found that the this one, the speaking valve tube is there, no? So we have put that one instead of, so that the air is coming out as we ventilate the patient. The air is coming out through the trachea into the esophagus, and so that it looks like it is not in the position. So these were the problems we encountered.
okay, Anna. So I have seen almost all the explained complications in my experience, from difficulty in putting the tracheal tube, and the bleeding complications, and false tracking leads to pneumothorax and cardiac arrest, and massive bleeding, immediate bleeding and late bleeding, and tube block leads to death. Almost every explained complication I have seen. The most dangerous thing is not the procedure of the tracheostomy, and the tracheostomy related complications leads to death. So you must be very careful during tracheostomy and after tracheostomy, even post tracheostomy, and patient shifted to ward. We used to get the calls that patient had cardiac arrest in the ward. Those days, in patient having single tube, single lumen. A single lumen is very high chances of developing a tube block. By the time you reach the patient may have cardiac arrest. So except the total removing the tube completely and intubate the patient, or even just pull out the tube, may save the patient life. So many complications we have to learn, and we have to have who had experience, they have to learn from that experience. and very important because immediate decision and immediate life-saving measures are very essential to save the patient. Any comments from seniors? Rani Madam, Anuradha, Srinivas, Monaga.
Sir, morning. Sir,
Hello?
I practice. Sir, morning. Vinisna? Hello.
Yeah, audible.
Yeah,
Sir.
go ahead. Okay,
David, sir.
Srinivas.
Sir. I've
Go ahead,
practiced
Srinivas.
all the. Sir, Vinisna? Hello.
వినిపిస్తుంది. Carry on.
Okay, sir. And we have practiced all the kinds of tracheostomies on the bedside, bronchoscopy guided, blind, Griggs, and single dilatational and multiple dilatational. Everything we have practiced. Out of all, maybe the safest you say is bronchoscopy guided, where you can see the needle guide and all those things. You are more on the safer side. And out of all, the learning curve will be slightly high with ultrasound guidance. So when you go with it, you have to direct the needle under ultrasound guidance. So it takes a little time to understand the rings and all those things. And mostly out of all the PDTs, mostly single dilatation is now very easily used, and single dilatation is better used. And the problem, obviously, what you're saying is WMIN is not available with the single dilatation technique. The tube what you get is a single one. And complications, mostly as the institution was having a good expertise, we haven't seen much complications. Just one I have faced is only difficult placement in a very obese lady with a high PEEP. We had to do a tracheostomy. So it was in my initial days. So it took a slightly longer time to put the tube, but obviously, as there is good expertise, so the consultant, my senior, has already put the tube. So the complications wise, we didn't see much complications. We have done patients on anticoagulation when we had to do, patients on dual antiplatelets when we had to do, patient on NOACs when we had to do, but we can minimize the bleeding with a good expertise. This is from my side, sir.
Madam. Hello.
Yeah, sir, audible.
Yeah.
Thank you, sir.
Any experience or any complications or any nightmares you have experienced in your
Hello.
Madam, good morning.
Madam,
Morning.
చెప్పండి.
Morning, David. Yeah.
Yes, madam. Go ahead.
Yeah, compared to percutaneous dilatational, maybe surgical complications less, but I have also seen complications during surgical tracheostomy in care only here. Obese patient, ICU patient, expected some problem. So anyway, like it was posted for theater only. Anesthetist was there and holding the tube little bit out, pull little bit out when the tracheostomy tube was going in, but I think got the tube pulled out completely, ET tube, and this tracheostomy tube didn't go in place. It created a false tract, so could not intubate. I mean, could not ventilate. So they realized immediately, but there was a lot of trauma, I think, during re-intubation. So anesthetist had problem in putting the tube in place, could not intubate, and repeatedly the tracheostomy went into false tract. I could not ventilate. So there was a crash call from unit 2. So from unit 1, like a few of us went in a hurry Still the procedure was going on, trying both ways, trying to intubate, trying to put the trachea in. It was real nightmare, and patient arrested in OT. So eventually tracheostomy tube only went in. When we saw by laryngoscope, it was all trauma, it was all bloody area, couldn't see anything. It looked like a mucosal tear and everything. I don't know where the tube went, and because it was difficult and they couldn't do. But anyway, we shifted the patient to ICU, but declared. So it was real nightmare to the surgeon, to us, to everybody, and that was anticipated only, but still the surgical one had problems. So we have to have, in difficult cases, we should not lose the airway. Like somehow when he said pull it out means we should have known it should be little bit into the cords, not completely out. So, and could not re-intubate and could not ventilate. So such things can happen. And on top of it, as we all do, like DVT prophylaxis we give, so more oozing. It was only, I think the patient was only on Flexane OD dose, but still whether it could be due to trauma, it could be due to Flexane, whatever the reason is. There was a lot of blood due to trauma and this one. And yeah, so these things can happen. So never forget such things. So particularly obese short neck patients have to be very careful. Maybe that time we were not using bronchoscope much, but if there was a bronchoscope in theater prepared for that also, maybe we would have prevented this arrest. Yeah.
Yes, madam. Even with bronchoscope also, sometimes you may not visualize anything because of bleeding. Wherever you go, we see only blood. So it is very difficult that time using bronchoscope also.
Yeah.
And one complication recently I have seen, morning tracheostomy was done and night 10 o'clock patient developed surgical emphysema around the neck. Neck was swollen like anything. And face also swollen. He developed severe surgical emphysema. We are unable to ventilate the patient because of this massive surgical emphysema.
Okay.
And that night, my colleague is afraid of because he is also difficult intubation. And what ENT surgeon told, remove the sutures on both sides, so that the air will escape from the sides of the incision, and air will go out. So what he thought, if you remove the both stitches, tube may come out and we may lose the airway. So what we did, we opened one side and slowly it escaped some air, and we pressed the air to escape. And another side also later, after some time, removed. By morning, patient surgical emphysema has come down more than 15%. We are able to ventilate the patient. So this type of very unusual, very rare complications also will develop. Madam, you saw one patient, no? One father of one lawyer created issues in care one. The patient bleeding means 20-25 days after tracheostomy, patient had massive bleeding and leads to death. Shani madam, no, I think.
Yeah, I think I
Madam,
vaguely remember. Yeah. I vaguely remember. Yeah. And we had another patient also.
One old man came to NRI.
Yeah.
Yeah, bleeding there. You see, after 20-25 days, he had massive bleeding. We were unable to control, and patient died. because of
Right.
bleeding after almost 25 days after tracheostomy.
Yeah.
So it is
Yeah, I
always
remember.
very,
Yeah.
yes, madam.
Another patient also, we were
So my
about to
advice,
discharge in 1-2 days, and
yes, madam.
suddenly started torrential bleeding. I think it's because of erosion of some vessels in the trachea. So
Vessel, yes.
if they start that kind of fresh and frank bleed, and which you can't stop, then we are gone. Like we can't do anything that time. We lose
Yeah.
the patient.
Before
That
shifting
happened
OT,
to another
we may
patient.
lose.
Yeah,
Yeah.
we lost another patient like that.
And David, what is the cause of this surgical emphysema in this patient?
Yeah. There was what he told. Maybe the tube is length is not sufficient. Some part of the tube inside, some part is outside, like that.
But you will see the leak, no? Why
So
surgical
that
emphysema?
time
సార్
No,
కొన్నిసార్లు మిస్పొజిషన్ అయినప్పుడు దెర్ ఇస్
leak.
ఛాన్స్ దట్ యూ కెన్ గెట్ కాదు అదే సార్ ఏదైతే లెంగ్త్ సరిపోకపోతే
leak లేదన్న.
సమ్ టైమ్స్ యూ విల్ గెట్ సర్జికల్ ఎంఫసిమా.
Is it any injury to the
Maybe he
esophagus or
thought that
injury to the trachea? So is it a percutaneous tracheostomy or surgical tracheostomy?
లేదు.
Huh?
Procedure is very good, and the surgical procedure was good, and initially till evening it was good. Patient was ventilating without any problem. Then started slowly bulging of the neck,
Pneumothorax is
light
there in that?
pace,
And
everything
pneumothorax?
is swollen, and we are unable. Luckily, patient developed no pneumothorax. Actually, we wanted to pull out the tube and reintubate, but by the time every area also, we are unable to put the laryngoscope. Very difficult to put the laryngoscope
After
for
removing the
intubation also,
filter,
because that
patient
area also
can
is
get it.
swollen. So what ENT surgeon told, don't remove the tube. If you are confident to put the endotracheal tube traditionally, don't do this one, but put the laryngoscope, and we are airway is totally is closed because of the swelling of the neck. So we are unable to visualize anything. So he said, don't remove the tube, remove both stitches, and push the neck to escape the air, like dynamic hyperinflation ఉంటుంది కదా ఆ type లో. So we succeeded luckily. Then the patient recovered well, and he discharged out. Decannulation also done after 15 days.
పోస్ట్ ట్రెకియోస్టమీ ఒకసారి సో ఈఎన్టీ వాళ్ళు బ్రాంకోస్కోప్ చేస్తాను, దే వాంటెడ్ టు సీ సమ్ ట్రెకి అండ్ ఆల్ దోస్ థింగ్, అండ్ దే హావ్ డన్ ఎ బ్రాంకోస్కోపీ అండ్ దే హావ్ మిస్ప్లేస్డ్, అంటే మీలా సేమ్ కండిషన్ సార్, అండ్ ద ట్యూబ్ వాజ్ మిస్ప్లేస్డ్ అండ్ దెర్ ఈస్ ఎక్స్టెన్సివ్ సర్జికల్ ఎంఫిసిమా, అండ్ ఒక అరగంట కూడా పేషెంట్ సర్వైవ్ అవ్వలేదు. సో వీ లాస్ట్ ద పేషెంట్. దట్ ఈస్ పోస్ట్ లైక్ 5 to 6 days after tracheostomy. That this happened.
అంటే మిస్ప్లేస్ అంటే ఎక్కడ పోయింది అది?
అది తెలియదు సార్, అదే చెప్తాను. డ్యూరింగ్ ద ప్రొసీజర్ వాళ్ళు బ్రాంకోస్కోప్ మ్యానిపులేట్ చేసినప్పుడు ట్యూబ్ ఏం చేశారో తెలియదు. అంటే ఇట్ హ్యాస్, అంటే హాఫ్ ఆఫ్ ద ట్యూబ్ ఏమో స్కిన్ లోని, హాఫ్ ఏమో లూమెన్ లోని, అలాగా. దట్ ఈస్ ద రీజన్ ప్రాబబ్లీ వాట్. రైట్ సార్, చూసి తీస్తున్నారు. సో ఆ మ్యానిపులేషన్ అంటే ఎక్కడ మిస్ అయిపోయింది. వీ కేమ్ వెన్ దెర్ ఈస్ అ సర్జికల్ ఎంఫిసిమా. ఇంకా ఆ తర్వాత ఇంకా లోపల పెడతానికి అవ్వలేదు, ట్యూబ్ వేయడానికి అవ్వలేదు, ఏం లేదు. విత్ ఇన్ హాఫ్ అన్ అవర్ పేషెంట్ గాట్ అరెస్టెడ్. అంతే సార్, అదే
ట్రాక్ పోయి ఉంటుంది. Anna, they have given one case scenario in EDIC. This is my EDIC 2. The case scenario is given. What they told, patient posted for tracheostomy, you have done the tracheostomy as intensivist, whatever the procedure, maybe they have given percutaneous only. During procedure, patient have developed complications and bleeding, false tracking. You are unable to succeed, and patient had a cardiac arrest, hypoxia, cardiac arrest. So how do you approach this scenario? They gave me this scenario. సో మన ఇండియాలో జనరల్ గా కాంప్లికేషన్ వచ్చింది, ఇలా అయింది, నా అరెస్ట్ అయ్యాడు బికాస్ ఆఫ్ ది కాంప్లికేషన్ ఆఫ్ ది పేషెంట్ అని చెప్పం కదా. వీ డోంట్ కమిట్ యూజువల్లీ బికాస్ ఆఫ్ ఫియర్. సో వాట్ దే ఎక్స్పెక్టెడ్ దట్ sorry, it is a complication, I have done my best. So because of during procedure patient developed some complications like pulse tracking, and which are explained complications, rare but explained complications. Because of that, patient developed hypoxia followed by cardiac arrest, and I did the CPR, everything, and tried to revive the patient. Finally, I intubated the patient and succeeded in intubation and ventilated. But by the time, because of severe hypoxia, brain was damaged and patient in unconscious state due to hypoxic brain damage. Sorry for that. It is a complication. I could not save the patient like that. We have to tell like that. Is it possible in India?
సగంలోనే కొట్టేస్తారు సార్.
నాట్ పాసిబుల్. ఫస్ట్
Huh?
కొడతాడు, తర్వాత అడ్మినిస్ట్రేటర్ జాబ్ తీసేస్తాడు.
But they expected the same answer from that. They told me that
వాళ్ళు ఏదైనా
we have to tell
అడిగే ఉంది.
ఎగ్జామ్ లో చెప్తాము.
ఆడు నన్ను వేసేసాడు, దాంట్లో ఫెయిల్ చేసి పడేసాడు. అది
ఎగ్జామ్ లో చెప్తామండి, మేము ఇలా చెప్తాము.
మేము అలా చెప్పమంటే చెప్పాను, అయినా కూడా నువ్వు అసలు ఆ మాట అన్నందుకే నువ్వు వేసేసాడు కదా. As per guidelines, we have to tell sir, but it is practical issues are there. We cannot tell. No, I don't accept. So whatever they do mistakes, they will commit in. Madam, I know, madam, you know that.
David, అక్కడ వాళ్ళు they are trying to elicit from you informed consent and కాంప్లికేషన్స్, పాసిబుల్ కాంప్లికేషన్స్ అవన్నీ ఎక్స్ప్లెయిన్ చేసామా, అది కన్సెంట్ ఉందా, అందుకే మనం స్టార్ట్ చేసాము. బట్ అన్ఫార్చునేట్లీ ఇలాగైంది, డిఫికల్ట్ అయింది, ఇట్లా అరెస్ట్ అయ్యారు. బ్రేకింగ్ ద బ్యాడ్ న్యూస్, అన్ని రకాల ఆన్సర్స్ they want to elicit from you. కూడా అక్కడ ఏదో చేసుకుంటావు, పేషెంట్ పోతాడు ఎలా చెప్తామని అడుగుతుంటారు, చాలా సార్లు అడుగుతారు. ఇంటర్వ్యూస్ లో కూడా ఆ క్వశ్చన్స్ ఉంటాయి.
ఇది వరకు ఇది చెప్పాం, ఏది కన్సెంట్, కాంప్లికేషన్స్, ఎవ్రీథింగ్, వీడియో కాల్స్, ఎవ్రీథింగ్ ఇస్ డన్. బట్ కమిటింగ్ ద మీన్స్ మిస్టేక్, I have done this thing happened because of that patient died, ఇలాగా అంత ఫ్రీగా మనం చెప్పలేం కదా.
అంత ఫ్రీగా చెప్పలేము, కానీ we tried our best, but anticipated problem ఉంటే, anticipated problem we tried to take all the precautions, we tried our best, but this happened అని చెప్పాలనే చెప్తారు, చెప్పకుండా ఉంటేనే అక్కడ పోతుంది. అదే
చెప్పాలి. యూ హ్యావ్ టు టెల్ ద ట్రూత్. కానీ నేను అనేది ఏంటంటే, ఇండియాలో ప్రతి జరిగిన ఇన్సిడెంట్ ని మనం బయటికి అంత ఫ్రీగా చెప్పలేం కదా. ఇట్ ఈస్ డిఫికల్ట్. నెంబర్ ఆఫ్ కాంప్లికేషన్స్ మే అరైజ్, బట్ వీ డోంట్ రివీల్ ఎవ్రీథింగ్ లైక్ ఇన్ ఫారిన్ కంట్రీస్ వాట్ దే హావ్. ఇట్ ఈస్ మ్యాండేటరీ దేర్, బట్ ఇట్ ఈస్ నాట్ ఇన్ ఇండియా. we will try to cover.
చెప్తాము ఏదో కానీ, బట్ ఐడియల్ గా కొంతన్నా చెప్తాము. ఇక్కడ కూడా అసలు చెప్పకుండా ఉన్నాం కదా.
అదే చెప్తాం, అసలు చెప్పకుండా ఎలా ఉంటాం. ఓటీలో తీసుకెళ్లి పేషెంట్ అండ్ యాక్సెప్ట్ చేయరు కదా. ఏదో చెప్తాం, అంటే కాంప్లికేషన్ వచ్చింది చెప్తాం కానీ, బట్ అంత మొత్తం ఎవ్రీథింగ్ వీ కెనాట్ రివీల్.
ఇప్పుడు నేను చెప్పిన ఓటీలో ట్రెకియాస్మీ కాంప్లికేషన్ వచ్చి అరెస్ట్ అయిన గురించి పైకి షిఫ్ట్ చేసిన తర్వాత కొంచెం చెప్పాము ఇలా చాలా డిఫికల్ట్ అయింది, చాలా టైం పట్టింది. ఇన్ఫాక్ట్ వాళ్ళు మధ్యలో అక్కడ తలుపులు కొట్టేస్తున్నారు. ఏంటంటే ఏంటి 2 గంటలు అయింది బయటికి దాటలేదు ట్రెకియాస్మిక్ తీసుకెళ్ళని. సో అప్పుడు చెప్పాం డిఫికల్ట్ అవుతోంది ప్రొసీజర్, బ్లీడ్ అవుతోంది, వీఆర్ ట్రయింగ్ అది ఇదని. మధ్యలో ఒకసారి అరెస్ట్ అయింది బట్ రివైవ్ అయింది అని చెప్పి అవన్నీ చెప్పి పైన ఐసీయూకి తీసుకెళ్ళిన తర్వాత రిథమ్ అయితే వచ్చింది. బట్ ఐఎమ్ షూర్ హైపాక్సిక్ డ్యామేజ్ అయ్యే ఉంటుంది. బట్ పైకి వెళ్ళిన తర్వాత మళ్ళీ రిపీటెడ్ అరెస్ట్ అయితే ఇంకా డిక్లేర్ చేస్తాము. అంటే ఒక్కొక్కసారి we should know the pulse of the attendance trouble makers లాగా అనిపిస్తే ఇంకాస్త జాగ్రత్తగా ఉండాలి. బట్ దిస్ పర్టికులర్లీ వాళ్ళు అంత ఇది కాదు, దే హావ్ బీన్ ఓకే ఫ్రమ్ ద బిగినింగ్. సో వాళ్ళకి చెప్పాము అప్పుడు. బట్ వీ హ్యావ్ టు బి కేర్ఫుల్. అందుకనే ప్రాబ్లం అవ్వచ్చు అనుకున్న కేసు గురించి ఇంక్లూడింగ్ ఆన్ టేబుల్ కాంప్లికేషన్స్, డెత్, బ్లీడింగ్ అవన్నీ కూడా చెప్పే తీసుకుంటే బెటర్.
Yeah. Any thoughts from the audience? Hello, Srikanth.
Yeah, sir. Thank you, sir. Thank you so much.
Thank you. Yeah. Thank you all for your active participation. And we'll close the session and we'll meet in the next one. Thank you.
Thank you, David.
Thank you, sir.
Thank you, Srikanth.
Thanks, Anna.
Yeah.
Thank you.